Thank you, Dr. Vora. Now we'll proceed to the next speaker, Dr. Ashish Nabar. We'll have the questions at the end of the session. Dr. Ashish Nabar also doesn't need any introduction, and he'll be talking on alternate side pacing.
It's an honor to speak in front of Dr. Pailajani and Dr. Satyavan Sharma. Thanks AOC for this invite. And also I must thank Dr. Gupta for bringing cardiology academics to Navi Mumbai. I think when Milind gave me this talk, probably what he meant was conduction system pacing, although it is worded as alternate side pacing. And through the talk, I will tell you why I'm restricting myself to left bundle area pacing. One of the things that the electrophysiologist likes in addition to maintaining sinus rhythm is to have a narrow QRS. And obviously there is a data for it. If you look at the heart failure patients, the wider the QRS, the higher the mortality. And therefore, if you were to reverse this trend, you should probably have a narrow QRS, particularly when you are pacing. And to achieve narrow QRS, what could be best than stimulating the conduction system? As you can see in this cartoon, conduction system pacing can be done at different levels. It can be his bundle or in the bundle branches, because from there on downstream the activation will proceed by the conduction system and will activate both the ventricles and thus have a shortest biventricular activation time. But most of us are now restricted to left bundle area pacing rather than his bundle pacing for the following reasons. One is that the learning curve for left bundle area pacing is pretty short. There is less dislodgement of the lead, the thresholds remain stable over time, and there is less oversensing because the his bundle lead is at the annulus, there is a chance of atrial oversensing. So enough reasons for most of us kind of average implanters to maintain ourselves at left bundle area pacing, and his bundle pacing is now less and less practiced. Now where do we use this left bundle area pacing? It can obviously, the most important reason to do it is probably patients who have cardiomyopathy. There will be a lot of overlap between what I speak and Dr. Vora spoke, but the most common indication is to treat a symptomatic or a advanced heart failure with LV systolic dysfunction. Yes, it is also useful to prevent pacing-induced cardiomyopathy and probably to prevent pacing-induced cardiomyopathy as well as treat pacing-induced cardiomyopathy. So if you see this spectrum of indications, you might want to believe that left bundle area pacing should be the uniform way to do RV endocardial pacing. Are we that far? Probably not, because we don't have randomized controlled trials to substantiate all the indications as a class 1 indication. Let's see some of the cases. The first set of cases are probably with relation to treating advanced heart failure with LV systolic dysfunction. Now, as you heard in the previous talk, it is mainly CRT and it still remains a class 1 indication for patients with heart failure with reduced ejection fraction, a LVBP kind of a QRS, and advanced level of symptoms. Now, here you can see in the panel B that the QRS doesn't every time reduce to what we intend to, but yet in the major trials, there is a definitely proven benefit in the randomized control trials of doing CRT in this peculiar subset of heart failure patients. Whether it is CRT-P or CRT-D is an individualistic decision. Let me start here with this case, a young lady who has a moderate LV systolic dysfunction, symptomatic, and has a moderate MR. Now this QRS is definitely LBBB-like and certainly wide, maybe 130, 140 milliseconds, not really 150 plus. But because of her level of symptoms, it was chosen to do a left bundle area pacing. Now what I want to show you here is one second. So I think, so you can see that the target vein here is pretty big. So getting into the coronary sinus, depositing the lead in the right vein is not a problem. But when I tried to remove the sheath, at least 5 times the lead would slip out because it's a large vein and the takeoff is pretty early. So in this case, I switched to left bundle area pacing and obtained a ECG like this at the end of pacing. Now, not necessarily too brilliant in terms of narrowing of the QRS, certainly less than what we had to start with. This is called as deep septal pacing, but I'll deal with it a little more in detail. But after 3 months, the referring cardiologist did report that the MR was reduced, the LV function improved, and symptomatically the patient was better. Here is another case which was a standard CRT indication which should be over in 2.5 hours. But it did not, because unfortunately the sheath dissected the coronary sinus, and therefore in previous situations or in previously we would have stopped the case there because I don't see the target branch anymore and probably come back on another day. Not today. We fell back on the left bundle area pacing. So this is the sheath which supports the stylet driven screw in lead, and it is screwed in the septum. The left bundle area pacing, if you look at this ECG, is obviously quite successful because the paced QRS is pretty narrow, and in the follow-up this patient did do well. So what I have kind of put forth in these last two cases is left bundle area pacing certainly comes as a bailout when you cannot place the CS lead adequately. What are the proven benefits? Left bundle area pacing definitely has a shorter procedure time, shorter fluoroscopy time. Lead thresholds are lesser than the CRT. So this is all in comparison to the conventional CRT. The acute hemodynamics effects are better. The paced QRS is narrower. The change in LVF is better. The thresholds are good, and the lead related complications are lesser. If I enumerate all these points to you, one might think that left bundle area pacing should be a class 1A indication above the CRT. Not yet. But you can certainly make use in patients whom you want to be on the catheterization table for shortest possible time. Now look at this lady, a nonagenarian who has a complete heart block, has a LV ejection fraction of 35% and a non-sustained VT documented during the ICU stay. Now obviously she makes indication for a CRT-D, but at 85 with a creatinine of 1.8, I want her to be on the table for a very short time. So this is some little improvisation with the hardware that we have today. What you see here is a DX ICD lead which will take care of AV synchrony. You don't get atrial pacing here, but you have a possibility of A-sense V-pace. You have a DF lead, so the ICD is completed, and in the LV port of this CRT-D device, you do a left bundle area pacing lead and put that lead in the LV port. So we have only two leads. We don't spend a lot of time giving contrast and locating the CS branch, and also we have a shorter stay on the table. If this is the QRS that I can obtain, then I think it's worthwhile, and therefore these are some of the niche indications where you can be a little more imaginative and keep the table time very short. Now, yes, left bundle area pacing for heart failure has definitely been superior in terms of how the paced QRS looks, the lead parameters which remain stable, and low procedure related complications. And in long term, there is also a heart failure hospitalization and mortality benefit. What more do you want, you would think? The problem is that all our data is from observational trials. Yes, the QRS is narrow, the ejection fraction is better, there is the LV end systolic volume goes down, the NT-proBNP improves, there is a reduced heart failure hospitalization and a reduced mortality. But all this is borne out only from the observational trials, and we are probably waiting for the randomized control trials. This is still more evidence before the RCTs are available. If you look through this recent publication, the meta-analysis also shows that the QRS duration is shorter than CRT, the NYHA class is better, the LV ejection fraction is better, but yet we are lacking in terms of the randomized control trials, and that is why it is not a class 1A indication. Is left bundle area very simple? Can we reproducibly do it all the times is the question. If you look at the left bundle anatomy, it is between the RCC and NCC on the left side before it branches out into left anterior and posterior fascicle. And then screwing the lead should seem to be, with the hardware available, should seem to be a relatively simple job. But is it reproducible? Is our roadmap good enough? Possibly not, because of the anatomical variations that you have. If you look at the work of Henry Kulbertus, you will understand that the left bundle anatomy is not the same all the time in every patient. And therefore, our roadmap is a little insufficient to achieve the same result every time and reproducibly. It depends on how deep you drill. If you just go into the septum, it is called as deep septal pacing. If you drill still deeper, then you capture the myocardium and at higher outputs you capture the conduction system. Whereas if your tip of the lead is on the left bundle, then you get a selective left bundle capture. So you have different types of left bundle pacing as deep septal, non-selective left bundle capture or selective left bundle capture. It also depends where along the RV surface you start drilling. For example, maybe you will capture the left bundle as you can see in the last panel, or you may capture the left anterior fascicle, or you may capture the left posterior fascicle. All this you can differentiate obviously from the ECG. But whether that decides what clinical result you obtain, again, probably not different, but this will again need some study, and therefore we call it left bundle branch area pacing and not left bundle pacing. What is the further role of this technique then? I think you already heard that CRT does have non-responders. 1/3 of the patients are non-responders who do not have a clinical or echocardiographic improvement for various reasons, like the CS lead could not be implanted, or the threshold for the CS lead was high, or you get phrenic nerve stimulation, so you cannot do the CS lead. In that case, will the left bundle area pacing be useful every time? Probably not, because left bundle area pacing would be most suited to correct the broad QRS when the delay is in the conduction system. But if you have a scar in the ventricle, this would not be corrected by simply doing a left bundle area pacing. And that's where Dr. Vora alluded to what is cardiac physiologic pacing. And that's the term that we use now. And whenever you are doing a CRT, we should have arrangements to fall back or add a left bundle area pacing to the CRT pacing. What that means is your RV lead, you should be ready to do it in a left bundle area pacing manner, and your CS lead should be quadripolar. Bipolar leads are no longer used. Yes, your conduction system pacing can also be His bundle pacing, but as I alluded to earlier, most of us now have switched to left bundle area pacing rather than His bundle pacing because of definite advantages. I think I have said some of them, but left bundle area pacing or even the LOT CRT, so left bundle optimized CRT with the CS lead has a lot of QRS reduction and clinical benefits. Here is another case of a middle-aged lady who has a standard indication for CRT, a non-ischemic cardiomyopathy with a left bundle branch kind of a QRS. It's pretty standard. But what happened is that so this is the result that I got when you did RV left bundle branch pacing as well as the CS lead. Now this is the QRS that you would believe innately that if it comes to as narrow as that, this patient is certainly going to be a responder. Therefore, the benefit of thinking of combining the left bundle area pacing with the CS lead. One more example here as how the LOT CRT would be required. For example, in this case, there is a posterolateral vein, but although it could be wired, one could not push the CS lead down. So therefore, I chose a posterior rather than the posterolateral branch. The more medial you are to the septum, the less likely the QRS is going to be narrow. And therefore, in these peculiar situations, it is worthwhile to do the left bundle area pacing lead in addition to this lead in the posterior ventricle. So on table, depending on the QRS width, one should be able to decide whether adding left bundle area pacing would be good. Look at this QRS, and certainly this would make us happy at the end of the procedure. Dr. Vora alluded to some non-left bundle branch block type of wide QRS and how good are the indications for a CRT procedure. In the left, there is a left bundle branch area block. The red means early, blue means late. But some of these right bundle branch blocks could be with a delay in both the ventricles, particularly when you have right bundle branch with the left axis. And these patients could still be a target for a CRT procedure. So I think you should not exclude every right bundle branch block pacing as non-indicated for a CRT procedure, especially now that you have left bundle area pacing and a LOT CRT possibility available. The second subset that I want to discuss is pacing-induced cardiomyopathy. So here is an 85-year-old lady who has permanent AF with complete heart block. Now you are going to do, obviously in this patient, a single chamber pacemaker because AF, no sense of doing a dual chamber pacemaker. If in this lady you were to do a ventricular RV endocardial pacing, you are likely to make a wide QRS, and this patient could develop a LV dysfunction over time, which is called as pacing-induced cardiomyopathy. So instead of doing the ventricular pacing the usual way, we got left bundle area pacing and resulting in a narrow QRS. Similarly, this elderly lady has a AT and AF recurrently happening, persistent AT-AF with tachycardiomyopathy. Again, it was thought beneficial to ablate the AV node and do a left bundle area pacing instead of a usual. The dual chamber pacemaker is because she has a persistent ATAF and not a permanent ATAF. So this is the QRS that you can get, which is pretty narrow than your normal RV endocardial pacing. A lot of TAVRs are happening in the city. A lot of SAVRs were always happening, and many times these patients land up in complete heart block, and they could be having a pre-existing LV systolic dysfunction. This is one case where the surgical replacement of the aortic valve is done, has a complete heart block post-procedure, and we could get a narrow QRS by doing a left bundle area pacing in this patient. Pediatric patients are also important because they will have the RV endocardial pacing for a longer time. Can we do a left bundle area pacing? Probably with this Medtronic lead, which is a thin and a long lead, you can do that probably, and this lead will sustain probably the integrity for a longer time. This patient has a balloon pulmonary valvotomy and a ASD, a 10-year-old child with left bundle area pacing. If you give this kind of a QRS, I have an intuition to believe that this narrow QRS would have less chance of making a pacing-induced cardiomyopathy. This is probably a last set of patients where you have immediately after doing a RV endocardial pacing, in a few months you land up with a tachycardiomyopathy, and believe me, it does happen once in a while. So this is a middle-aged old male where the RV endocardial pacing was done by putting the RV lead in the apex. Now this is the worst position to do a pacing today. Such a wide QRS is obviously a sore to the eye. This lead had to be removed and a left bundle area pacing had to be done to have an improvement in LV function. That's obviously because of a narrow QRS that could be obtained like that. So you have different modalities of doing left bundle area pacing. His bundle pacing can be practiced but requires a lot of skills. Left bundle area pacing is a little simpler. Whenever required in heart failure, you can combine it with a CS lead. Are there concerns? Surely there are concerns. I think last 4 or 5 years we might be doing this. So the long-term lead performance, we are not sure as to how it will be because these leads were never meant to be screwed into the septum like this. We don't know, extraction is required more and more for different reasons. How well these leads are extracted, we do not know. What do they do to the tricuspid regurgitation? That's still something to know. There are going to be difficult subsets like your post-TAVR or post-SAVR or HCM. The septum are thick, how well you can drill it to capture it the left bundle. And the algorithms probably need to get better so that we can do the conduction system pacing better. I think I'll stop here with these conclusions that conduction system pacing is a promising option to CRT, not necessarily above CRT. His bundle pacing is limited because of the skills and because of certain technical difficulties associated with it. Left bundle area pacing is much more doable, and doing in a hybrid way with the standard conventional CRT is definitely an option, and one should plan your CRT case always with the possibility to do a left bundle area pacing as a backup or as supplementing the CS lead. I stop here and I thank you for your patient listening. Thank you very much.
Thank you, Ashish.